All right, jumping right back into it again. We're gonna read the hypersensitivity, allergy, autoimmunity, and alloimmunity, the mechanisms of hypersensitivity, antigenic targets, and hypersensitivity reactions, as well as the autoimmune, alloimmune disease. We're not gonna get into deficiencies in immunity, as it's not being covered in our upcoming test. So let's jump right back into it. The immune system is a finely tuned network that protects the host against foreign antigens, particularly infection or infectious agents. Sometimes this network breaks down, causing the immune system to react inappropriately. Inappropriate immune responses may be one, exaggerated against environmental antigens, such as allergies, misdirected against the host's own cells, such as autoimmunity, or directed against a beneficial foreign tissue, such as transfusions or transplants, alloimmunity. And number four, be insufficient to protect the host, an overall immune deficiency. All of these can be serious or life-threatening, as exaggerated immune response allergy are most common, but usually the least life-threatening. Tell that to someone who's got a peanut allergy. Alright, so the hypersensitivity, allergy, autoimmunity, and alloimmunity. Hypersensitivity is an altered immunologic response to an antigen that results in disease or damage to the host. Hypersensitivity reactions can be classified in two ways: by the source of the antigen that the immune system is attacking, allergy, autoimmunity, alloimmunity, look at table 9.1, and by the mechanism that causes it, types 1, 2, 3, and 4. Look at table 9.3. Allergy originally denoted both facets of the immune response: immunity, which is beneficial, and hypersensitivity, which is harmful. Allergy has now come to mean the deleterious effects of hypersensitivity to environmental antigens, and immunity means the protective response to antigens expressed by the disease-causing agent. So, an example of this is environmental antigens in allergies, such as hay fever, which may contribute to autoimmunity via self-antigens, which may contribute to some type of type 3 reaction. I don't think there's a positive or negative alloimmunity. And another person antigens may contribute to some type of type 3 reaction. Ooh, okay. So there is a type 1 immunoglobulin IgE mediated, which is very positive with allergies. Then there's a type 2 tissue specific allergy. So, for instance, the hemolysis in drug allergies, which would be its environmental antigen. There is a positive autoimmunity to that. The self-antigens is an autoimmune thrombocytopenia because the hemolysis in the cells that's happening. There is a positive reaction to alloimmunity, and another person's hemolytic disease or another person's antigens, which could cause hemolytic disease in newborn babies. Then we have type 3, the immune complex, such as gluten or wheat allergy, those who have the gluten allergies. Um, it's an allergic reaction, so yes, it's positive to that. But it's very positive due to the autoimmunity aspect of it. The systemic lupus erythematosus, or self-antigen in that aspect. It is positive for alloimmunity, and it can cause anaphylaxis to IgA in type 4 gamma globulins. And then there is a cell-mediated type 4 allergy, such as poison ivy. Again, it's an allergic reaction to an environmental antigen. There is a positive autoimmunity, the self-antigens or Hashimoto thyroiditis is positive to alloimmunity, and another person's antigens could cause a graft rejection. Um, so the plus and minus are how common it is in each section. Some very common, some not so much. Autoimmunity is a disturbance in the immunologic tolerance of self-antigens. The immune system normally does not strongly recognize the individual's own antigens. Healthy individuals of all ages, but particularly older adults, may produce low quantities of antibodies against their own antigens, autoantibodies, without development of overt autoimmune disease. Therefore, the presence of low quantities of autoantibodies does not necessarily indicate a disease state. Autoimmune disorder occurs when the immune system reacts against self-antigens, such as a degree that the person's own tissues are damaged by autoantibodies or autoreactive T cells. Many clinical disorders are associated with autoimmunity and are collectively referred to as autoimmune diseases. So autoimmune diseases could include Graves' disease, autoimmune thyroiditis, primary myxedema, all of which come from the thyroid gland and could be caused by either receptors for thyroid stimulating hormone on plasma membrane of the thyroid or thyroglobulin microsomes or just microsomes. The pancreas could cause insulin-dependent diabetes, which is an islet cell, insulin and insulin receptors on the pancreatic cells. The adrenal gland could be affected via Addison's disease, where the surface antigens on steroid-producing cells and microsomes of the adrenal cortex are affected. Your ovary has two such options: premature gonadal failure or female infertility via the interstitial cells or corpus luteum and zona pellucida. And on the male side, we have the testes, which can cause male infertility, or orchitis, which is a surface antigen on the spermatozoa and germinal epithelium. Your parathyroid gland may be infected via the idiopathic hypoparathyroidism, where surface antigens on chief cells, epithelial cells of the gland. The pituitary gland may be affected via the partial pituitary deficiency, prolactin-producing cells, which contribute to growth hormone-producing cells. The skin can also be affected. We can have pemphigus vulgaris, bullous pemphigoid, dermatitis or herpetiformis, or vitiligo, which could be the intracellular substances in stratified squamous epithelium. They could be in the basement membrane, or they could be in the basement membrane of the immunoglobulin A or IgA, or the surface antigen on melanocytes or melanin-producing cells. They can also affect the musculature, so pylomyositis, which is the nuclear material in myosin. Multiple sclerosis is a neural tissue defect where the cause is unknown. Myasthenia gravis is a neuromuscular junction where acetylcholine receptors and striation of skeletal and cardiac muscle are affected. The nerve cell via polyneuritis, which is the peripheral myelin being affected. The heart can have rheumatic fever or cardiomyopathy, which is cardiac tissue subsil subsarcolemmal membrane, or cross-reaction with group A streptococcal antigens, or with myopathy, the increase in cardiac muscle, the central nervous system, post-vaccinal or post-infectious encephalitis can cause a central nervous system myelin or basic protein. Okay, I've read through like a large portion of these. They can also affect your GI system, the gut, the eyes, the connective tissue, the renal system. Pretty much anything that is in the body could potentially be affected with some kind of disorder of autoimmunity, given the chance. So, with that being said, alloimmunity is also termed isoimmunity, occurs when the immune system of one individual produces a reaction against tissue of another individual. Alloimmunity can be observed during the immunologic reaction against transfusions, transplanted tissue, or the fetus during pregnancy. The mechanism that initiates the onset of hypersensitivity, whether it consists of allergy, autoimmunity, or alloimmunity, is not completely understood. It is generally accepted that genetic, infectious, and possibly environmental factors contribute to the hypersensitivity. Most diseases caused by hypersensitivity develop because of the interaction of at least three variables: an original insult, which alters the immunologic homeostasis, the individual's genetic makeup, which determines the degree of the resultant immune response from the effect of the insult, and the immunologic process that causes the symptoms of the disease. Our mechanism of hypersensitivity, therefore, is a disease or diseases that caused by the hypersensitivity reaction can be characterized also by the particular immune mechanism that results in the disease. These mechanisms are apparent in most hypersensitivity reactions and have divided into four distinct types of type 1, immunoglobulin IgE-mediated hypersensitivity reaction, type 2, tissue-specific hypersensitivity reactions, type 3, immune complex-mediated hypersensitivity reactions, and type 4, cell-mediated hypersensitivity reactions, looking at table 9.3. This classification of artificial and seldom is a particular disease associated with only a single mechanism. The four mechanisms are interrelated, and in most hypersensitivity reactions, several mechanisms can be at work simultaneously and sequentially. Some of the mechanisms are secondary to the disease and not directly involved in the pathologic process, whereas others are the primary cause of tissue destruction. Right. So again, we've got four types of mechanisms. Type 1 is IgE, which is an immediate result. The class of antibody involved obviously would be IgE. The principal effector cells involved are our mast cells. And the complementary participation is not there. And then it cuts off, because why wouldn't it? Time to buy the full book, I fear. Type 2, tissue-specific reaction, is also immediate. It is our IgG and IgM that gets mostly infected or affected and is mostly involved. The principal effector cells are the macrophages in tissues, and there is a complement participation that is frequently activated. Type 3, the immune complex mediated reaction, is also immediate. Those are our IgG and IgM antibodies. But these affect specifically our neutrophils, and yes, there is a complement participation. Lastly, our cell-mediated reaction, or type 4, which has a delayed reaction. There is no type of specific antibody involved. However, there are our lymphocytes and macrophages with no complementary participation. Bless you. Hypersensitivity reactions require sensitization against a particular antigen that results in primary and secondary immune responses. An individual is sensitized when an adequate amount of antibodies or T cells is available to cause a noticeable reaction on re-exposure to the antigen. Some individuals become sensitized quite rapidly after an apparent single exposure to the antigen, while others require multiple exposures that may occur over years. After sensitization has been achieved, hypersensitivity reaction can be immediate or delayed depending on the time between re-exposure to the antigen and the onset of clinical symptoms. Reactions that occur within minutes to a few hours are termed immediate hypersensitivity reactions. Delayed hypersensitivity reactions may take several hours to appear and are at maximum severity days after re-exposure to the antigen. The most rapid and severe immediate hypersensitivity reaction is anaphylaxis. Anaphylaxis occurs within minutes of re-exposure to the antigen and can be either systemic, generalized, or cutaneous, localized. Symptoms of systemic anaphylaxis include itching, erythema, headaches, vomiting, abdominal cramps, diarrhea, and breathing difficulties. The most severe reactions may include contraction of bronchial smooth muscle, laryngeal edema, and vascular collapse, and a decreased blood pressure that can lead to shock and death. Examples of systemic anaphylaxis are allergic reactions to bee stings, peanuts, eggs, and shellfish. Cutaneous anaphylaxis results in local symptoms such as pain, swelling, and redness, which occur at the site of exposure to an antigen, a painful local reaction to an injection vaccine or a drug. So, again, we are talking type 1 IgE-mediated hypersensitivity reactions. Type 1 of IgE-mediated hypersensitivity reactions are mediated by antigen-specific IgE and the products of tissue mast cells. The most common allergies, like pollen allergies, are type 1 reactions. In addition, most type 1 reactions occur against environmental antigens and are therefore allergic. Because of the strong association, many healthcare professionals use the term allergy to indicate only IgE-mediated reactions. However, IgE can contribute to a few autoimmune and alloimmune diseases, and many common allergies, such as poison ivy, are not mediated by IgE. I'm going to skip over some pictures here. In some individuals, exposure to an environmental antigen causes primarily IgE production. Repeated exposure to the antigen usually is required to elicit enough IgE so that the person becomes sensitized. IgE has a relatively short lifespan in the blood because it rapidly binds to very high affinity Fc receptors on the plasma membranes of mast cells. The subclass IgG4 has a specific receptors on the mast cells and may contribute to the type 1 mechanism. Antibody that binds to mast cells is termed cytotropic antibody, able to bind to cell surfaces, or reagen, skin sensitizing antibody. Unlike Fc receptors on phagocytes, which bind IgG that has reacted with antigen, the Fc receptor on mast cells bind with IgE that has not previously interacted with antigen. If further exposure of a sensitized individual to the antigen occurs, one molecule of antigen may bind simultaneously to two molecules of IgE Fc receptor complexes on the mast cell surface. They're cross-linked, resulting in activation of intracellular signaling pathways and mast cell degranulation. The antigen that triggers cross-linking must have at least two antigenic determinants on the same molecule. Sometimes an IgE-mediated response is beneficial to the host, as is the case of some immune reactions against parasites. The mechanism is described in Chapter 8 and illustrated. The products of mast cell degranulation can modulate almost all aspects of an acute inflammatory response. The most potent mediator is histamine, which affects several key target cells. Acting through the H1 receptors, histamine contracts bronchial smooth muscles, causing bronchial constriction, increasing vascular permeability, causing edema, and causes vasodilation, increasing blood flow into the affected area. The interaction of histamine and H2 receptors results in increased gastric acid secretion and a decrease of histamine released from mast cells and basophils. The action of histamine through H2 receptors suggests an important negative feedback mechanism that stops degranulation. That is, the released histamine inhibits release of additional histamine by interacting with H2 receptors on the mast cells. Histamine may also affect control of the immune response through H2 receptors on most cells of the immune system. Another important activity of histamine is enhancement of the chemotactic activity of other factors, such as the eosinophil chemotactic factor of anaphylaxis, which attracts eosinophils into sites of allergic inflammatory reaction and prevents them from migrating out of the inflammatory site. Blocking histamine receptors with antihistamines can control some type 1 responses, which is why we give antihistamines, such as Benadryl. Mast cells also initiate synthesis of bioactive lipid-deprived mediators such as leukotrienes, platelet-activating factor PAF, and prostaglandins. Each is released much more slowly than histamine and can mediate similar yet more prolonged clinical symptoms, such as recruiting inflammatory cells, or neutrophils and eosinophils, promoting vascular permeability and edema, inducing bronchoconstriction or rhinitis, and inducing further release of histamine from mast cells. Therapy includes the use of competitive inhibitors of receptors for lipid mediators, montelukast, a leukotriene receptor inhibitor, rupatadine, a PAF receptor inhibitor, and others are in clinical use. So that leads us to type 2 tissue-specific hypersensitivity reactions. So type 1, you're going to treat with Benadryl or antihistamines and montelukast and rupatadine. So let's talk about type 2. Type 2 tissue-specific hypersensitivity reactions are generally characterized by a specific cell or tissue being the target of an immune response. In addition to major histocompatibility locus antigens, human leukocyte antigens or HLAs, as discussed in Chapter 8, most cells have other antigens on their surface. Some of these antigens are called tissue-specific antigens because they are expressed on the plasma membranes of only certain cells in specific tissues. Platelets, for example, have groups of antigens that are found on no other cells of the body. The symptoms of many type 2 diseases are determined by which tissue or organ expresses the particular antigen. Environmental antigens, drugs, or their metabolites may bind to the plasma membranes of specific cells, especially the erythrocytes and platelets, and function as targets of type 2 reaction. The 5 general mechanisms by which type 2 hypersensitivity reaction can affect cells is shown in figure 9.2. All of these mechanisms begin with antibody binding to tissue-specific antigens or antigens that have attached to particular tissues. First, the cell can be destroyed by antibody, IgG or IgM, and activation of the complement cascade through the classical pathway. Formation of the membrane attack complexes C5 through 9 damages the membrane and may result in lysis in the cells. For example, erythrocytes are destroyed by complement-mediated lysis in individuals with autoimmune hemolytic anemia, or as a result of alloimmune reactions to ABO mismatched transfused blood cells. Second, antibody may cause cell destruction through phagocytosis by macrophages, IgG, and also C3b of the complement system are opsonins that bind to receptors on the macrophage. Phagocytosis of the target cells follows. For example, antibodies against platelet-specific antigens or against red blood cell antigens of the Rh system coat those cells at low density, resulting in their preferential removal by phagocytosis in the spleen, rather than by complement-mediated lysis. Third, antibody and complement may attract neutrophils, either antigen expressed normally on the vessel walls or soluble antigen in the circulation, which are released from cells within the body or from infectious agents or by way of drugs or medications that has been deposited on the surface of endothelial cells may bind antibody. The antibody initiates the complement cascade, resulting in the release of C3a and C5a, which are chemotactic for neutrophils, and deposition of complement component C3b. Neutrophils bind to the tissues through receptors of Fc portions of antibody, Fc receptors, or for C3b, and attempt to phagocytose the tissue. Because the tissue is large, phagocytosis cannot be completed. Even though neutrophils release their granules onto the healthy tissue, the components of neutrophil granules, as well as the several toxic oxygen products produced by these cells, will damage the tissue. And then our fourth mechanism is the antibody-dependent cell-mediated cytotoxicity, ADCC. This mechanism involves a subpopulation of cytotoxic cells that are not antigen-specific, so natural killer cells. Antibody on the cell is recognized by Fc receptors on the NK, or natural killer cells, which release toxic substances that destroy the target cell. So that's very generic, and yeah, doesn't really care. So lastly, I think the fifth and last one here is the fifth mechanism does not destroy the target cell, but rather causes it to malfunction. In this mechanism of type 2 injury, the antibody is usually directed against antigenic determinants associated with specific cell surface receptors. And the symptoms of the disease are a result of a direct effect of antibody binding alone. The antibody reacts with the receptors on the target cell surface and modulates the function of the receptor by preventing interactions with their normal ligands, replacing the ligand and inappropriately stimulating the receptor or destroying the receptor. For example, in hyperthyroidism or excessive thyroid disease of Graves' disease, autoantibody binds to and activates receptors for thyroid-stimulating hormone, or TSH, a pituitary hormone that controls the production of the hormone thyroxine by the thyroid. In this way, the antibody stimulates the thyroid cells to produce thyroxine. Under normal conditions, the increased levels of thyroxine in the blood would signal the pituitary to decrease TSH production, which would result in less stimulation of the TSH receptor in the thyroid and a concomitant decrease in thyroxine production. Because the level of the anti-TSH receptor antibody is not controlled by the pituitary, increasing amounts of thyroxine in the blood have no effect on antibody levels, The thyroxine production continues to increase despite decreasing amounts of TSH. More of which we'll discuss in Chapter 22, if we discuss Chapter 22. I'm sure we will. Type 3, immune complex-mediated hypersensitivity reactions. Mechanism of type 3 hypersensitivity. So most type 3 immune complex-mediated hypersensitivity reactions are caused by antigen-antibody or immune complexes that are formed in the circulation and deposited later in vessel walls or extravascular tissues. The primary difference between type 2 and type 3 mechanism is that in type 2 hypersensitivity, antibody binds to the antigen on the cell surface, whereas in type 3, the antibody binds to soluble antigens that was released into the blood or body fluids, and the complex is then deposited into the tissues. So again, type 2 mechanism of hypersensitivity, antibody binds to the antigen on the cellular level, whereas type 3 binds to the soluble antigen that was already released into the blood and is therefore dropped off into the body's tissues. Type 3 reactions are not organ-specific, and symptoms have little to do with the particular autogenic target of the antibody. The harmful effects of the immune complex deposition are caused by complement activation, particularly through the generation of chemotactic factors for neutrophils. The neutrophils bind to antibody and C3b contained in the complexes and attempt to ingest the immune complexes. So there is an attempt. They are often unsuccessful because the complexes are bound to large areas of tissue. During the attempted phagocytosis, large quantities of lysosome enzymes are released into the inflammatory site instead of into phagolysosomes. The attraction of neutrophils and the subsequent release of lysosomal enzymes cause most of the resulting tissue damage. The immune complex can be of various size, depending on the relative amount of antigen and antibody. Fairly large immune complexes are cleared rapidly from the circulation by tissue macrophages, where very small complexes eventually are filtered from blood through the kidneys without any pathologic consequences. Intermediate-sized immune complexes, formed at the ratio of antigen to antibody that has a slight excess of antigen, are likely to be deposited in certain target tissues where they have severe pathological consequences, such as the inflammation in the kidneys, glomerular, oh boy, glomero, oh my god, speak, Chris, speak, glomerulonephritis, glomerulonephritis, jeez, I am struggling today. The vessels and vasculitis, or the joints, arthritis, or degenerative joint disease. Okay, speaking today. Oh boy. All right. So, our immune complex disease. The nature of the immune complexes may change during the progression of the disease, with resultant changes in the severity of the symptoms. Immune complex formation is dynamic because variations in the ratio of antigen to antibody, the class and subclass of antibody, and the quantity and quality of circulating antigen occur. Thus, complexes formed early in a disease process may differ from those formed later. And several types of immune complexes may be present simultaneously. With the tremendous potential heterogeneity of immune complexes, it is not surprising that immune complex diseases are characterized by a variety of symptoms and periods of remission and exacerbation of symptoms. Because many immune complexes activate complement very effectively, complement levels in the blood may decrease during active disease. At times, the individual's blood may become hypocomplementic, which means that it contains below normal amounts of complement activity during type 1, 2, and 4 hypersensitivity reactions. Complement levels are unaffected, or some components of the complement cascade, such as C3, may even be increased. Two prototypic models of type 3 hypersensitivity help explain the variety of disease in this category. Serum sickness is a model of systemic type 3 hypersensitivity, and the Arthus reaction is a model of localized or cutaneous reactions. Serum sickness, the systemic prototype of immune complex-mediated disease, is called serum sickness because it was initially described as being caused by the therapeutic administration of foreign serum, such as horse serum that contained antibodies against tetanus toxin. Foreign serum generally is not administered to individuals today, although serum sickness reactions can be caused by the repeated IV administration of other antigens, such as drugs. And the characteristics of serum sickness are observed in systemic type 3 autoimmune diseases. Serum sickness type reactions are caused by the formation of immune complexes in the blood and their subsequent generalized deposit and deposition in target tissues. Typically, affected tissues are the blood vessels, joints, and kidneys. Other symptoms include fever, enlarged lymph nodes, rash, and pain at the site of inflammation. A form of serum sickness is Raynaud phenomenon, a condition caused by the temperature-dependent deposition of the immune complexes in the capillary beds of the peripheral circulation. Certain immune complexes precipitate at temperatures below normal temperature, particularly in the tips of the fingers, toes, and nose, are called cryoglobulins. The precipitates block the circulation and cause localized pallor and numbness, followed by a cyanosis, or bluish tinge resulting from oxygen deprivation, and eventually gangrene if the circulation is not restored. The Arthus reaction. An Arthus reaction is the prototypic example of a localized immune complex-mediated inflammatory response. It is caused by repeated local exposure to an antigen that reacts with preformed antibody and forms immune complexes in the walls of the local blood vessels. Symptoms of an Arthus reaction begin within 1 hour of exposure and peak at 6 to 12 hours later. The lesions are characterized by a typical inflammatory reaction with increased vascular permeability, an accumulation of neutrophils, edema, hemorrhage, clotting, and tissue damage. All of which leads us to type 4 of the cell-mediated hypersensitivity reaction. Whereas type 1, 2, and 3 hypersensitivity reactions are mediated by antibody, type 4, or cell-mediated hypersensitivity reactions, are mediated by T lymphocytes and do not involve antibody. Type 4 mechanism occurs through either cytotoxic T lymphocytes, the TC cells, or lymphokine-producing Th1 and Th17 cells. TC cells attack and destroy cellular targets directly. Th1 and 17 cells produce cytokines that recruit and activate phagocytic cells, especially are macrophages. Destruction of the tissue is usually caused by direct killing of toxins from TC cells or by the release of soluble factors such as lysosomal enzymes and toxic reactive oxygen species, which is our ROS, from activating macrophages. Clinical examples of type 4 hypersensitivity reactions include graft rejection, and allergic reactions resulting from contact with such substances such as poison ivy and metals. A type 4 component also may be present in many autoimmune diseases. For example, T cells against type 2 collagen, a protein present in joint tissues, contribute to the destruction of joints and rheumatoid arthritis. T cells against thyroid cells, surface antigen, contribute to the destruction of the thyroid and autoimmune thyroiditis, or Hashimoto disease. And T cells against an antigen on the surface of the pancreatic beta cells, the cells that normally produce insulin, are responsible for beta cell destruction in insulin-dependent type 1 diabetic mellitus. So, a type 4 hypersensitivity reaction in the skin was thoroughly described first by Ehrlich in 1891 and led to the development of diagnostic skin tests for tuberculosis. The reaction follows an intradermal injection of tuberculin antigen into a suitably sensitized individual and is so-called a delayed hypersensitivity skin test. Because of its slow onset, 24 to 72 hours to reach maximum intensity, the reaction site is infiltrated with T lymphocytes and macrophages, resulting in a clear hard center in duration and a reddish surrounding area, erythema. So, the antigenic targets of hypersensitivity reaction, or allergy. Allergy is a hypersensitivity response against the environmental antigen, allergen. Allergies is the most common hypersensitivity reaction. The most common allergies are type 1 hypersensitivities, although any of the other three mechanisms of hypersensitivity may cause allergic responses, depending on the particular allergen. Typical allergens that induce type 1 hypersensitivity include pollens, like ragweed, molds and fungi, Penicillium notatum, foods like milk, eggs, and shellfish, and animals, cat dander, dog dander, cigarette smoke components of house dust, the fecal pellets of house mites, and almost anything else encountered in the environment. Allergens that primarily elicit type 4 allergic hypersensitivities include plant resins, poison ivy, poison oak, metals such as nickel and chromium, and acetylates, and chemicals and rubber, cosmetics, detergents, and topical antibiotics. Neomycin. Type 2 and type 3 allergic hypersensitivities are relatively rare but may include antibiotics like penicillin and sulfonamides, and soluble antigen produced by infectious agents like hepatitis B. Usually, a sensitization process involving multiple exposures to the allergen occur before adequate amounts of antibody or T cells are available to elicit a hypersensitivity response. In some instances, exposure to a particular allergen may not be apparent in the case of allergens that are drugs, additives, or preservatives in food. For example, an individual may become sensitized by drinking milk that contains trace amounts of penicillin used for treating cows for mastitis. Thus, the first therapeutic exposure to penicillin may cause an unexpected hypersensitivity reaction. Additionally, penicillins share a beta-lactam structure with cephalosporin, so that one antibiotic may be sensitive against another. There's also a genetic predisposition. Certain individuals are genetically predisposed to develop allergies, particularly type 1 allergies, and are called atopic. In families in which one parent has an allergy, allergies develop in about 40% of their offspring. If both parents have allergies, the incidence in the offspring may be as high as 80%. Atopic individuals tend to produce higher quantities of IgE and to have more Fc receptors for IgE on their mast cells. The airways and the skin of the atopic individuals are also more responsive to a wide variety of both specific and non-specific stimuli than are on airways and skin of individuals who are not atopic. Multiple genes have been associated with the atopic state, including polymorphism in a large variety of cytokines that regulate IgE synthesis, so our interleukin 4, 5, 12, and 13, and cellular receptors. Clinical symptoms of type 1 allergies include, well, the clinical manifestations of type 1 reactions are attributable mostly to the biologic effects of histamine. Tissues most commonly affected contain large numbers of mast cells and are sensitive to the effects of histamine release from them. These tissues are found in the gastrointestinal tract, the skin, and respiratory tract. The particular symptoms frequently reflect the main portal of entry for the allergen. For instance, pollens and other airborne allergens usually cause respiratory symptoms. And there is a whole list of things. We'll skip over that though. Effects of allergens on the mucosa of the eyes, nose, and respiratory tract include conjunctivitis, the inflammation of the membranes lining the eyelids, rhinitis, inflammation of the mucous membranes of the nose, asthma, the constriction of the bronchi. Symptoms are caused by vasodilation, hypersecretions of mucus, edema, and swelling of the respiratory mucosa. Because the mucous membranes lining the respiratory tract, the accessory sinuses, nasopharynx, and upper and lower respiratory tract are continuous, they are all adversely affected. The degree to which each is affected determines the symptoms of the disease. Urticaria or hives is a dermal skin manifestation of type 1 allergic reactions. The underlying mechanism is the localized release of histamine and increased vascular permeability, resulting in limited areas of edema. Urticaria is characterized by white fluid-filled blisters, or wheals, surrounded by areas of redness, flares. The wheal and flare reaction is usually accompanied by itching. Not all urticarial symptoms are caused by allergic or immunologic reactions. Some termed non-immunologic urticaria result from exposure to cold temperatures, emotional stress, medications, systemic disease, hyperthyroidism, and malignancies such as lymphomas. Gastrointestinal allergies are caused primarily by allergens that enter through the mouth, usually food and medicine. When food is the allergen, the active immunogen may be a product of food breakdown by digestive enzymes. Symptoms usually occur rapidly, frequently within minutes, and they can include vomiting, diarrhea, abdominal pain, and may be severe enough to result in malabsorption or protein losing enteropathy if the reactions are prolonged or recurrent. Systemic symptoms may range from urticaria to life-threatening anaphylactic reactions. The most common allergies are milk, chocolate, eggs, soy, wheat, tree nuts, peanuts, shellfish, and fish. The incidence of food allergies in children is estimated at 2% to 10% and has been increasing. Most children, about 75, outgrow food allergies, but most individuals with peanut allergies, about 80%, will remain sensitive through adulthood, with the potential of severe reactions. If possible, avoidance of the allergen is the best method to limit allergic responses. Approximately 30% of laboratory animal handlers have allergies to animal dander and must use face masks or other devices to avoid contact. Although some type 1 allergic responses can be controlled by blocking histamine receptors with antihistamines, the primary mechanism of control is the autonomic nervous system. The autonomic nervous system includes biochemical mediators, epinephrine and acetylcholine, that, like the mediators of the inflammatory response, have profound effects on cells. These mediators bind to appropriate receptors on mast cells and the target cells of inflammation, such as smooth muscle, thereby controlling the release of inflammatory mediators from mast cells, and 2. The degree to which cells respond to the inflammatory mediators. So, if our allergic disease is a bee sting, an example of a life-threatening allergy is an anaphylactic reaction to a bee sting. Bee venoms contain a mixture of enzymes and other proteins that may serve as allergens. About 1% of children may have an anaphylactic reaction to bee venom. Within minutes, they may develop excessive swelling, edema at the bee sting site, followed by generalized hives, itching, and swelling in areas distal from the sting, meaning eyes and lips, and other systemic symptoms including flushing, sweating, dizziness, and a headache. The most severe symptoms may include gastrointestinal, stomach cramps, vomiting, respiratory tightness in the throat, wheezing, difficulty breathing, and vascular, low blood pressure, shock. Reactions. Severe respiratory and vascular reactions may lead to death. If a child has had a previous anaphylactic reaction to bee stings, the chance of having another is about 60%. During the reaction, the administration of antihistamine has little effect because histamine has already bound H1 receptors and initiated severe bronchial smooth muscle contraction. Most individuals carry self-injectable epinephrine. Autonomic nervous system mediators, such as epinephrine, bind to specific receptors on smooth muscle and reverse the effects of histamine and result in muscle relaxation. Similar anaphylactic reactions have been described against peanuts and other nuts, shellfish, fish, milk, eggs, and some medications. So, tests of IgE-mediated allergy. Allergic reactions can be life-threatening. Therefore, it is essential that several allergic individuals be made aware of their specific allergens, against which they are sensitized and instructed to avoid contact with that material. Several tests available, including food challenges, skin tests with allergens, and laboratory tests for measurements of total IgE and allergen-specific IgE in the blood. Reactivity to a particular food allergen may be tested by controlled administration of small doses of the suspected allergen in order to evoke a mild allergic response. This approach can be dangerous if the individual has a history of anaphylactic responses. A safer approach is an injection of an allergen into intradermal or onto epicutaneous or prick test the skin. If the individual is allergic to a particular allergen, like local wheal or flare reaction may occur within a few minutes at the site of injection. The diameter of the flare reaction is usually indicative of the individual's degree of sensitivity to that allergen. In the most severely allergic individuals, even the extremely small amounts of allergen used for the skin test may evoke a systemic anaphylaxis. The skin test is also contraindicated if the individual is using medications that may affect the test or has diffuse dermatitis, which would make the reaction difficult to interpret. A variety of lab tests can detect IgE antibodies in serum. These assays have various commercial acronyms depending on whether they are radioimmunoassays RIAs, reactivity detected by measuring the radioactive reagent, or enzyme immunoassays EIAs, or ELISA, enzyme-linked immunosorbent assay. Reactivity detected by measuring a color change caused by the enzyme label reagent. One set of assays measuring circulating levels of total IgE with atopic individuals usually having elevated levels. Other assays are capable of measuring circulating levels of specific IgE antibodies against selected allergens. The amount of IgE against a specific allergen correlates well with the degree of skin test reactivity and the severity of clinical symptoms related to the same allergen, although the laboratory test is less sensitive. Desensitization. Clinical desensitization to allergens can be achieved. In some individuals, minute quantities of the allergen are injected in increasing doses over a prolonged period. The procedure may reduce the severity of allergic reactions in the treated individual and works best for routine respiratory tract allergens and biting insect allergens. 80 to 90% rate of desensitization over 5 years of treatment. However, this form of therapy is associated with a risk of systemic anaphylaxis, which can be severe and life-threatening. Food allergies have been very difficult to suppress, but some promising trials are underway to evaluate desensitization by oral or sublingual administration of increasing amounts of allergens. The mechanism by which desensitization occurs may be several, one of which is a production of large amounts of so-called blocking antibodies, usually circulating IgG. A blocking antibody presumably competes in the tissues or the circulation for binding with antigenic determinants on the allergen so that the allergen is neutralized and is unable to bind with IgE on mast cells. Sublingual desensitization, another approach that works best with some food allergies, produces SIgA and circulating IgG that may prevent the allergen from accessing mast cells. Desensitization injections also may stimulate the generation of clones of T regulatory lymphocytes, which inhibit hypersensitivity by suppressing the production of IgE or modifying the Th1-Th2 interactions in favor of production of anti-inflammatory cytokines. Other approaches to suppress type 1 allergic responses have been tested with some preliminary success. An example is injection of anti-IgE antibody directly against the Fc portion of the IgE in order to decrease binding of IgE to mast cells. The allergens that induce a type 4 allergic reaction are mostly haptens that react with normal self-proteins in the skin. When presented in this fashion, these antigens are recognized by pattern recognition receptors, or PRRs, on antigen-presenting cells in the skin, and induce a cell-mediated response, a pattern recognition receptor, or PRR. The primary result is an allergic contact dermatitis that is confined to the area of contact with the allergen. The best known example is poison ivy or poison oak, I'm assuming. The antigen in that instance is a plant catechol, urushiol, that reacts with normal skin proteins and evokes a cell-mediated immune response. So we get in contact with the So we get in contact with the catechol molecule and our skin molecule, and then it causes a reaction. Lovely. As noted, type 1 hypersensitivity reaction may result in a skin reaction. Hives formed during an allergic reaction to a particular food. The distribution of the lesion may suggest whether the reaction is caused by immediate type 1 or delayed type 4 hypersensitivity mechanism. Immediate hypersensitivity reactions termed atopic dermatitis are usually characterized by widely distributed lesions, whereas contact dermatitis, delayed hypersensitivity, consists of lesions only at the site of contact with the allergen, such as a metal allergy to jewelry. Now we're jumping back to type 2 and type 3 allergic hypersensitivities. Type 2 allergic hypersensitivities are usually against allergic haptens that bind to the surface of cells and elicit an IgG or IgM response. For instance, allergic reactions against many drugs, penicillins and sulfamides, occur after the drug binds to the proteins on the plasma membrane of the person's cell and becomes immunogenic. The immune system attacks the allergens on the cell membrane and destroys cells as well. The allergic reaction to penicillin, the immunogenic antigen, is a metabolite of penicillin catabolism that binds to the plasma membranes of erythrocytes or platelets and induces an antibody response that destroys the cells, a type 2 hypersensitivity, causing anemia or thrombocytopenia. Bless you. Type 2 allergic reactions also can occur against antigens of infectious disease. For instance, encephalitis secondary to the rubella infection may result from damage to cells of the nervous system by an immune response against rubella virus antigens on the cell's plasma membrane. Type 3 allergic reaction occur after the formation of immune complexes containing soluble allergens. For instance, Arthus reactions may be observed after ingestion, or inhalation of allergens. Skin reactions can follow subcutaneously and intradermal inoculation with drugs, fungal extracts, or antigens used in skin tests. Gastrointestinal reactions such as gluten sensitivity, enteropathy, celiac disease follow ingestion of antigen, usually gluten from wheat products. Allergic alveolitis is a type 3 acute hemorrhagic inflammation of the air sacs or alveoli of the lungs, resulting from the inhalation of fungal antigens, usually particles from moldy hay, or also known as farmer's lung or pigeon feces, the pigeon breeder's disease. Circulating drugs, penicillins, or antigens produced from infectious diseases, hepatitis B, streptococcal infection, may form circulating immune complexes that are deposited in the circulation, causing vasculitis or the kidneys. That happy word of glomerular nephritis. That's not the word though. It's glomerular. Oh my god. Can I say it? Glomerulonephritis. Glomerular. Oh my god. I can't. Not today. It's not happening. That's alright though. Talking about autoimmunity. Autoimmune disease originate from the coincidence of an initiating event in a genetically predisposed individual, leading to an autoimmune mechanism that affects specific target tissues or cells. Some autoimmune diseases can be familial and attributed to the presence of a very small number of susceptibility genes. Affected family members may not all develop the same disease, but have different disorders characterized by a variety of hypersensitivity reactions, including autoimmune and allergic. For instance, the HLA antigen B27. The HLA is discussed further under transplantation and transfusion as a risk factor for developing ankylosing spondylitis, an autoimmune disease of the spine. 95% of individuals diagnosed with ankylosing spondylitis express HLA-B27, whereas only 4 to 8% of the general population express this antigen. Although autoimmune disease appears as isolated events without positive family history, susceptibility for developing such diseases appears to be linked to a combination of multiple genes. Examples of associations between specific HLA alleles and diseases. Right. I'm not looking at all that. We'll skip over that. Genetic factors. Genetic factors that contribute to autoimmunity are easier to identify than the original insult that initiates the disease. It is fairly well established that autoimmune diseases can be familial. Affected family members may not all develop the same disease, but several members may have different disorders, characterized by a variety of hypersensitivity reactions, including autoimmune and allergic reactions. Associations with particular autoimmune diseases have been identified for a variety of major histocompatibility complexes, or MHC alleles, see Chapter 8, or non-MHC genes. The specific HLA alleles of susceptible and resistant individuals have been analyzed for almost every known disease, and almost universally, individuals with certain diseases are more likely than the general population to have a specific HLA allele or set of alleles. Some associations are strong, others are more tenuous. The reasons some HLA alleles are associated with inappropriate immune function is unclear, but it may be directly involved in the ability of a particular HLA molecule to present antigen or the use of particular HLAs as receptors for disease-causing microorganisms. These genes may determine an individual's susceptibility to specific infectious agents or the capacity of that individual to mount an immune response against specific antigens. Therefore, an individual of a specific HLA type may have an inappropriate or exaggerated immune response against a microorganism, resulting in the hypersensitivity reaction. A large variety of non-MHC genes also have been identified as risk factors for the development of specific autoimmune diseases. Most of these genes encode for inflammatory cytokines or co-stimulatory molecules found on the cell surface. So, there is a breakdown of tolerance. Individuals are usually tolerant of their own antigens. Tolerance is a state of immunologic control, so that the individuals do not make a detrimental immune response against their own cells and tissues. Central tolerance develops in humans during the embryonic period, and autoreactive lymphocytes are either eliminated or suppressed in the primary lymphoid organ during differentiation and proliferation of immature TMB lymphocytes. Clones of cells with antigen receptors for self-antigen are deleted, whereas peripheral tolerance is maintained in the secondary lymphoid organs through the action of T regulatory lymphocytes and antigen-presenting dendritic cells. The key term in the definition of tolerance is detrimental immune response, because autoimmune antibodies frequently are present or at low but measurable levels in the blood of most individuals. So we all have some form of autoimmune antibodies. They may perform a useful function, such as removing low levels of cellular debris from the blood, and are quantitatively and qualitatively regulated to avoid autoimmune disease. Autoimmune disease results more commonly from the breakdown of this peripheral tolerance, rather than a defect in central tolerance. An initiating event results in the breakdown of tolerance to an individual's own antigens. A great deal of research has progressively identified genetic risk or predisposing factors of autoimmune diseases, but in the vast majority of autoimmune diseases, the nature of the initiating event and the mechanism by which it breaks tolerance is unclear. Several potential mechanisms have been suggested, however. I think we're about to go into them. Sequestered antigen. The induction of central tolerance requires that the self-antigen be present in the fetus and exposed to the developing fetal immune system. Some self-antigen may not normally encounter the immune system in either fetal or adult life, but are sequestered or hidden from the immune system in immunologically privileged sites. So named because foreign tissues can be transplanted into the sites with less chance of immunologic reactions or rejection. For example, several sites, the anterior chamber of the eye, the brain, are separated from the circulation by barriers, the blood-ocular and blood-brain barrier, that offer protection against many immune cells and lead to relatively poor lymphatic drainage. Lymphocytes that enter these sites encounter tissues that express Fas ligands, or FASL, and tuber necrosis factor, TNF-related apoptosis inducing ligand trail. These molecules induce lymphocytes to undergo apoptosis, thus protecting the tissue. Self-antigens in these sites are protected by sequestration and an active protective mechanism. However, if the barriers are damaged, antigenic sensitization can occur, and the resulting antibodies and lymphocytes can enter the site and cause additional damage to the tissue. For instance, physical trauma to one eye may result in the release of sequestered antigen into the blood and lymphatics, resulting in immunologic injury to the other eye. A sympathetic uveitis. Infectious disease. A long-standing hypothesis is that foreign antigens from infectious microorganisms can initiate autoimmune disease through a process of molecular mimicry. Some antigens of infectious agents so closely resemble or mimic a particular self-antigen that antibodies or T cells produced to protect against the infection also recognize the self-antigen as foreign, a cross-reactive antibody or T cell. The relationship between many autoimmune diseases and predisposing infections, such as a link between enterovirus infection and type 1 diabetics, the link between the variety of infectious microorganisms and autoimmune thyroid disease, are being investigated. The only clear defined example so far is acute rheumatic fever that may occur after a group A streptococcal sore throat. In some individuals with group A streptococcal sore throat or infection of the skin or mucosa, the M protein and group A carbohydrate in the bacterial capsule mimic normal antigens in the heart valves and induce antibodies that also react with proteins in the heart valve, damaging the valve and allowing the influx of CD4 cells and specificities towards normal valvular antigens. Only a small number of individuals whose heart proteins has similar antigens to the bacterial capsular antigens are normally affected. Thus, acute rheumatic fever is initiated by a type 2 autoimmune hypersensitivity that may be augmented by the type 4 hypersensitivity. Additionally, some streptococcal infections also release soluble bacterial antigens into the blood that form circulating immune complexes with antibacterial antigens. The complexes may deposit in the kidneys and may initiate an immune complex-mediated glomerulonephritis, inflammation of the kidney. Thus, soluble streptococcal antigens may be a type 3 hypersensitivity mechanism, elicit of post-streptococcal glomerulonephritis, causing the circulating antigens are bacterial and thus environmental. This complication may be defined as a type 3 allergic reaction. And there's more. In certain situations, a neoantigen that induces an allergic reaction may also lead to autoimmunity. Many new antigens, are haptens that become immunogenic after binding to self-proteins. The immune reaction against a neoantigen may lead to an immunologic reaction against normal antigenic determinants on the protein. Other new antigen determinants may result in the post-translational modification of a normal protein, so that one or more amino acids are chemically altered, without affecting the protein's function. Many experimental autoimmune diseases can be initiated by immunization with molecules containing new antigenic determinants. New antigens may result from genetic or epigenetic modifications or post-translational modification, particularly in response to a lifestyle, such as smoking, diet, consumption of alcohol or coffee, exposure to organic solvents. These conditions are under investigation, but to date, only associations rather than clear causative relationships have been found. The forbidden clone. During differentiation and proliferation of lymphoid stem cells into immature T and B lymphocytes, some lymphocytes produce receptors that react with self-antigens. Many autoreactive lymphocytes interact with self-antigens and other costimulatory molecules on the surface of the thymic epithelial cells and are induced to undergo clonal deletion by a process of apoptosis. Thus, lymphocytes reactive against self-antigens are prevented or forbidden from maturing. Autoimmunity may result from the survival of a forbidden clone and its proliferation later in life. Ooh. Defective peripheral tolerance. Tolerance to some self-antigen is controlled in the secondary lymphoid organs. This process is controlled by a variety of cells, including antigen-presenting dendritic cells and members of a family of T regulatory lymphocytes, or Treg cells, that normally suppress immune response against the cell. Defects in particular regulatory cells may result in expansion of clones of autoreactive cells and the development of autoimmune disease. Systemic lupus erythematosus, which is characterized by a production of a large array of autoantibodies, may be caused by a general breakdown in the regulatory network. Silent imitators of autoimmune disease. The mechanism for imitation of autoimmune disease may already be within all humans. Two very interesting potential mechanisms are being explored. This is a case study, so we're going right over that. Lastly, alloimmunity. We're getting there. Hooray. Alloimmunity occurs when an individual's immune system reacts against antigens on the tissues of other members of the same species. Genetic diversity is the norm in humans. Diversity is also observed among self-antigens, so that two individuals may have different antigens on their tissues and therefore make an immune response against each other's tissues. Some self-antigens, such as the ABO blood group, have limited diversity, with very few different antigens being expressed in the population, whereas others, such as the HLA system, have tremendous diversity. Two clinically relevant examples of this reactivity are several transient neonatal diseases, in which a maternal immune system becomes sensitized against the antigens expressed by the fetus, and two, transplant rejection and transfusion reactions, in which the immune system of the recipient of a blood transplant or blood transfusion organ transplant reacts against the antigen on the donor cell. Transient neonatal alloimmunity. Because the fetus is a hybrid between the mother and father, it expresses paternal antigens that are not found in the mother. Occasionally, these fetal antigens cross the placenta and elicit an immune response in the mother. The production of alloantibodies against the fetal antigens, the maternal alloantibody may be transported across the placenta into the fetal circulation, bind to the fetal cells, and produce alloimmune disease in the fetus and neonate. The mother's immune system produces the antibody, but because the cells do not express the target antigen, the mother has no symptoms of the disease. Neonatal alloimmune disease may be secondary to maternal autoimmune disease, in which the mother produces an IgG autoantibody specific for maternal self-antigens that are found on fetal cells as well. Therefore, symptoms of the same autoimmune disease may affect mother and child, even though the autoantibody is being produced only by the mother's immune system. This form of disease usually occurs only in association with type 2 hypersensitivity reactions, It does not occur in association with IgE-mediated type 1 reactions, immune complex-mediated type 3 reactions, or cell-mediated type 4 reactions, because the immunologic factors of IgE immune complexes and T cells that cause reactions do not readily cross the placenta and enter the fetal's circulation in sufficient quantity. Symptoms of alloimmune disease may be present in utero or immediately after birth and may be fatal to the fetus or neonate. At birth, maternal circulating antibody can no longer enter the child, and if symptoms are successfully treated, the disease will disappear as the maternal antibody is catabolized. Examples of maternal immunologic hypersensitivity diseases in which the child can be affected include the following: Graves' disease, myasthenia gravis, immune thrombocytopenic purpura, alloimmune neutropenia, systemic lupus, erythematosus, RH and ABO, alloimmunization. So, autoimmune and alloimmune diseases. Many examples of autoimmune or alloimmune diseases have been described. Several basic principles are exemplified by two examples: systemic lupus erythematosus, an autoimmune disease, and tissue rejection, the transplant rejection or transfusion reaction, an alloimmune phenomenon. Most of the class autoimmune disease include disorders of the endocrine system. Autoimmune thyroiditis and Graves' disease, hematologic system, the hemolytic and pernicious anemias, nervous system, myasthenia gravis, and connective tissues such as rheumatoid arthritis are discussed in Unit 2 of this book. Sure. Are we talking about... Alright, we're getting there. We're close. Okay. Systemic lupus. Wow, I am now stumbling over words. Systemic lupus erythematosus is a chronic multi-system inflammatory disease and is one of the most common, complex, and serious of the autoimmune disorders. It is characterized by multiple immune disorders that result in the production of a large variety of autoantibodies against nucleic acids, erythrocytes, coagulation proteins, phospholipids, lymphocytes, platelets, and many other cell components. The most characteristic autoantibodies produced in lupus are against nucleic acids. I'm just going to call it lupus because that's what we all know it as. Single-stranded DNA, double-stranded DNA, histones, ribonucleoproteins, and other nuclear materials. Got it. The deposition of circulating immune complexes containing antibody against DNA produces tissue damage in individuals with lupus. DNA and DNA-containing immune complexes have high affinity for glomerular basement membranes, and therefore may be selectively deposited in the glomerulus, the kidney structures, as described in Chapter 38. The presence of DNA in the circulation increases from cellular damage in response to trauma, drugs, or infections, and is usually removed in the liver. Removal of circulating DNA is slowed in the presence of immune complexes, thereby increasing the potential of deposition in the kidney. The liver's role in removing waste products from blood is discussed in Chapter 41. The deposition of immune complexes composed of DNA and antibody also causes inflammatory lesions in the renal tubular basement membranes, the brain, the choroid plexus, heart, spleen, lungs, and the GI tract, and the peritoneum. Lupus, as with most autoimmune diseases, occur more often in women, approximately 10 to 1 predominance of females, especially in the 20 to 40-year-old age group. Blacks are affected more often than whites, about an eighth-fold increased risk. A genetic predisposition for the disease has been implicated on the basis of increased incidence in twins and the existence of autoimmune disease in the families with the individuals with lupus. A transient lupus-like syndrome that is indistinguishable both clinically and in the lab from spontaneous occurring lupus can develop from the prolonged use of medications, particularly hydralazine, an antihypertensive agent, and procainamide, an antidysrhythmic drug. In genetically susceptible individuals, certain environmental agents such as UV light and several infectious agents may trigger lupus-like immune reactions. Clinical, clinical manifestations of lupus include arthralgias or arthritis, vasculitis, and rash, renal disease, hematologic abnormalities, with anemia being the most common complication, and cardiovascular disease. A recent study of male and female individuals with lupus reported gender-based differences in the incidence of lupus-related symptoms. Females more commonly develop alopecia, photosensitivity, oral ulcers, malarush, lupus anticoagulant, arthritis, serosity with pleurisy, whereas males more commonly develop thrombocytopenia, anti-dsDNA, and renal involvement. As with most autoimmune diseases, the disease process develops slowly, up to 10 years from occurrence from the first autoantibody until diagnosis, and is characterized by frequent remission and exacerbations. Because the signs and symptoms affect almost every body system and tend to be intermittent, lupus is extremely difficult to diagnose. This has been the development of a list of 11 common clinical findings, which have been modified slightly to increase the sensitivity of diagnosis. The serial and simultaneous presence of at least 4 of them indicates the individual has lupus. A facial rash, discoid rash, photosensitivity, oral and nasopharyngeal ulcers, non-erosive arthritis of at least 2 peripheral joints, cirrhoticity, a renal disorder, a neurological disorder, hematological disorders, immunologic disorders, and the presence of an anti-nuclear antibody. Lab diagnosis is usually based on a positive ANA screening test. About 98% of persons with lupus are positive, but a substantial number of false positives occur in healthy individuals and those with other diseases, because lupus is a progressive and slowly developing disease. Some lab tests, including the ANA, may be positive years before the onset of clinical symptoms. Detection of a positive ANA is usually followed by one or more specific tests, antibodies against SM or dsDNA, that are complicated by low sensitivity. Only a portion of individuals with SLE will be positive, although the number of falsely positive is low. There is no cure for lupus, or most other autoimmune diseases. In the 1950s, the expected survival rate at 5 years was diagnosed was only about 50%. Because of the improved diagnosis and treatment of lupus, the 2004 expected survival rate is 20 years after diagnosis, with about a 78%. Fatalities resulting from lupus are usually related to cardiovascular disease, with infection and other organ failure as common. The goal of treatment is to control symptom and prevent further damage by suppressing the autoimmune response. Mild forms of lupus are treated with non-steroidal anti-inflammatory drugs such as aspirin, ibuprofen, and naproxen to reduce inflammation and relieve pain. Low-dose corticosteroids such as prednisone are often prescribed with higher doses used for more serious active disease. Anti-malarial medications, hydroxychloroquine, are preferred treatments for individuals with stable disease. Immunosuppressive drugs, methotrexate, acetioprine, and cyclophosphamide, are used to treat individuals with severe symptoms. involving internal organs who have not responded to higher doses of corticosteroids. UV light can worsen symptoms known as flares, and protection from sun exposure is helpful. Prolonged use of certain drugs can cause transient lupus-like symptoms, and the medication history is important for diagnostic evaluation. Other therapeutic approaches have been attempted for lupus and other autoimmune diseases. Several decades ago, preparation of IV immunoglobulin (IVIG), which was routinely used to replenish antibodies in persons with antibody deficiencies, were administered to children with autoimmune thrombocytopenia. IVIG therapy resulted in a rebound of platelet levels and the temporary resolution of thrombocytopenia. IVIG is currently being used for a variety of autoimmune diseases, including lupus. A monoclonal antibody, belimumab, inhibitors of factors that activate B cells and has been used in some individuals with lupus. Other reagents have specifically targeted and suppressed B and T cells that are participating in autoimmune responses. This approach has been somewhat successful in lupus, rheumatoid arthritis, and autoimmune diseases. Improving outcomes may be available in the future with the continued advances in individual research and the use of stem cell treatments. Okay, I'm almost done. Transfusion reactions. Red blood cells, erythrocytes, express several important surface antigens known collectively as the blood group antigen that can be targets of alloimmune reactions. More than 80 different red cell antigens are grouped into several dozen blood group systems. The most important of these, because they provoke the strongest humoral alloimmune response, are the ABO and RH system. The ABO system, human blood transfusion, were carried out as early as 1818, but they were often unsuccessful. Sometimes after a transfusion, the recipient red blood cells would clump together, thereby blocking the capillaries and causing death in some instances. In 1901, Karl Landsteiner reported that this reaction was related to the ABO antigen located on the surface of erythrocytes. The ABO blood group consists of two major carbohydrate antigens labeled A and B that are expressed in virtually all cells. These are codominant so that both A and B can be simultaneously expressed, resulting in an individual having any one of four different blood types. The erythrocytes of persons with blood type A express the type A carbohydrate antigen. Those with blood type B express the B antigen, and those with blood type AB express both A and B antigens on the same cell. And those of blood type O express neither A nor B. A person with type A blood also has circulating antibodies to the B carbohydrate. If this person receives containing B antigens, a severe transfusion reaction occurs and the transfused erythrocytes are destroyed by agglutination, or complement-mediated lysis. Similarly, a type B individual who cannot receive blood from a type A or a type AB donor. Type O individuals who have neither A nor B antigen but have both anti-A and anti-B antibodies cannot accept blood from any of the three types. These naturally occurring antibodies, called isohemagglutinin, are IgM and induced early in life by similar antigens expressed on naturally occurring bacteria in the intestinal tract. Because individuals with type O lack both types of antigens, they are considered universal donors, meaning that anyone can accept their red blood cells. Similarly, type AB individuals are considered universal recipients because they lack both A and B antibodies and can be transfused with ABO blood type. When large volumes of whole blood are transfused, However, antibodies in the donor's blood can bind to antigenic determinants on the recipient's erythrocytes, causing agglutination of the recipient's own cells. Preparation of pooled immunoglobulins are routinely administered intravenously (IVIG) to treat those who have immune deficiencies lacking antibodies. Transfusion reaction can occur if the IVIG contains excess levels of isohemagglutinins against the recipient's A or B antigens. Harmful transfusion reaction can be prevented only by complete and careful ABO matching between donor and recipient, because ABO antigens are also expressed on all other cells except platelets. ABO typing and matching also must be performed before organ transplantation. Rh blood groups is a group of antigens expressed only on red blood cells. This group is the most polymorphic system of red cell antigens, consisting of at least 50 separate antigens. At least 5 major antigens and a large number of rare variants have been identified and expressed primarily on the erythrocytes. The major antigen are contained on 2 proteins encoded from 2 closely linked genes, the RHD and RHCE. The RHD protein expresses the dominant antigen, which determines whether an individual is Rh positive or negative. Individuals who express the D antigen on the RHD protein are Rh positive, whereas individuals who do not express the D antigen are Rh negative. The letter D is used to indicate the lack of D Rh positive. Wait, what? The D is used to indicate a lack of D. Okay, and what is D? Rh positive individuals can have either DD or D small t genotypes, whereas Rh negative individuals have a small d genotype. Sure, about 50% of American whites are Rh negative, whereas Rh negative genotypes is much less common among members of other ethnic groups. Rh negative individuals can make anti-D if exposed to Rh positive erythrocytes, but because the letter D is used to indicate the lack of D antigen and does not represent a different antigen. Rh positive individuals do not produce an antibody against D. The second protein, RHCE, expresses 2 antigens, C and E, each of which has different alleles. Therefore, 4 potential haplotypes of C and E antigen are commonly observed. Okay, but it doesn't actually tell us what that is. That's fine. A disease called hemolytic disease of the newborn was most commonly caused by IgG anti-D alloantibody produced by Rh negative mothers against erythrocytes of their Rh positive fetuses. The mother's antibody crossed the placenta and destroyed the red blood cells of the fetus. The occurrence of this particular form of disease has decreased dramatically because of the use of prophylactic IgG anti-D immunoglobulin. By mechanisms that are still not completely understood, administration of anti-D antibody within a few days of exposure to RHD positive erythrocytes completely prevents sensitization against the D antigen. Because hemolytic disease of the newborn related to the D antigen has been controlled, alloantibodies against the other Rh antigens, usually C, C, or E, have become more important. In general, these alloantibodies are associated with less severe hemolytic disease, a form of autoimmune hemolytic anemia often caused by autoantibodies against Rh antigens, especially the E antigen. This variant is caused by IgG antibodies that react with erythrocytes at normal body temperature and increase phagocytic destruction of the red blood cell. This characteristic differentiates the warm variant from other form of autoimmune hemolytic anemia, which is caused by IgM antibodies that react optimally with erythrocytes in the cooler portion of the body, fingers and toes, and is referred to as cold autoimmune hemolytic anemia. Okay, graft rejection. Molecules of the major histocompatibility complex, MHC, were discussed in Chapter 8 as antigen-presenting molecules. This major histocompatibility complex molecules are also a major target of transplant rejection. As a result of studies of transplantation, the human major histocompatibility complex molecules are also referred to as human leukocyte antigens, or HLAs, and the different major histocompatibility complex genetic loci are commonly called human leukocyte antigen-A, B, C, DR, DQ, and DP. Additionally, genes for complement components C4 and factor B also are contained in the major histocompatibility complex region and are referred to as class 3 loci. The class 1 human leukocyte antigen A, B, and C, and class 2 of major histocompatibility complex loci, your HLA, DR, DQ, and DP, are the most genetically diverse, polymorphic of any human genetic loci. Okay, all that was mumbo jumbo, and I didn't understand a single word of any of that. So let's just skip over it and see what happens. With the human diverse polymorphic, nope, with the human population, the number of possible different alleles expressed by each locus is astounding. For example, more than 300 different HLA molecules are expressed in the population. These numbers are based on the polymorphism of the observed DNA sequences and may not reflect differences in function. Clearly, not every allele is expressed in the same individual. Humans have 2 copies of each MHC locus, one from each parent, that is codominant so that the molecules encoded by each parent's genes are expressed on the surface of every cell, except erythrocytes. Within an individual, each locus will express only one allele. For instance, each person will have the most 2 HLA-A proteins. A specific combination of alleles at 6 major HLA loci on the chromosome ABC, DR, DQ, and DP are termed haplotype. Yeah, you guys just copied that from Chapter 8 and plugged it back in here. We've definitely read that before. Each individual has 2 HLA haplotypes, one from the paternal chromosome 6 and another from the maternal chromosome. Right, we definitely read that. Odds dictate that children will share one haplotype with half their sibling and either no haplotypes or both haplotypes with a quarter of their siblings. Thus, the chance of finding a match among siblings is 25%. Yeah, we definitely read this. Because of the tremendous number of possibilities alleles expressed throughout the population, the probability of matching any 2 unrelated individuals is extremely small. Not all HLA loci are equally important. Matching at the HLA-DR locus appears to be the most critical for graft acceptance, and matching the HLA and HLA-B of slighter importance. Yeah, we discussed this in Chapter 8, definitely. So let's talk about the transplant rejection. It is classified as hyperacute, acute, or chronic, depending on the amount of time that elapses between the transplantation and rejection. Hyperacute rejection is immediate and rare. When the circulation is reestablished to the grafted area, the graft may immediately turn white, the so-called white graft instead of a normal pink. Hyperacute rejection occurs usually in recipients with pre-existing antibody type 2 reaction to HLA antigens on vascular endothelium in the graft. The antibodies may have resulted from rejection of a previous graft or from previous blood transfusions that contained platelets and white blood cells with foreign HLA. Additionally, about half of women who have had multiple pregnancies have circulating antibodies against their husband's HLA antigens. As the circulation to the graft is established, antibodies bind to the vascular endothelial cells in the graft tissues and activate the inflammatory response, including the coagulation cascade, which results in stasis of blood flow into the tissue. Biopsies of the graft often showed deposits of antibody IgG and IgM complement and neutrophils. This condition is rare because the effect of pre-transplantation cross-matching, during which the recipient is tested for antibodies against the HLA antigen of the potential donor. The acute rejection is primarily a cell-mediated immune response that occurs within days to months after transplantation. This type of rejection occurs when the recipient develops an immune response against unmatched HLA after transplantation. Sensitization is usually initiated by the recipient's lymphocytes interacting with the donor's dendritic cells within the transplanted tissue, resulting in the induction of recipient Th1 and Tc cells against the donor's antigens. The Th1 cells release cytokines that activate infiltrating macrophages, and the Tc cells directly attack the endothelial cells in the transplanted tissue. A biopsy of the rejected organ usually shows an infiltration of lymphocytes and macrophages, characteristic of type 4 reaction. Immunosuppressive drugs may delay or lessen the intensity of acute rejection. Then another form of acute rejection, acute antibody-mediated rejection, has recently been recognized and accounts for about 10% of acute rejection. This form of rejection is mediated by antibody and complement. The predominantly antibodies are against HLA antigens or, on occasion, autoantigens in the graft, vimentin, angiotensin receptors. But unlike those antibodies that cause hyperacute rejection are not present at the time of transplantation, sensitization takes 2 weeks or longer and results in the accumulation of antibody, complement, neutrophils, thrombi, and a vasculature of the graft. Last is the chronic rejection. May occur after a period of months or years of normal function. It is characterized by a slow progressive organ failure. Chronic rejection usually results from a weak cell-mediated immunologic type 4 reaction against a minor histocompatibility antigen on the grafted tissue. However, antibodies against HLA and other antigens also may cause chronic rejection through activation of complement or antibody-dependent cellular cytotoxicity within natural killer cells. And there we have it. Whew, we did it. I think we will call it a night for here. We discussed all that we need to discuss for Chapter 9, and we'll continue on next time with Chapter 10. So, for those who stuck around, you heard me read a lot. We'll keep on going. Until next time.